All right, good afternoon, everyone, and welcome to our webinar this afternoon. Thank you very much for joining us. My name is Grace Suva, and my picture is on the right of your screen, and I'm one of the managers on the implementation science team here at RNAO, and I will be the moderator for today's webinar. I'd also like to introduce you to Andrea Stubbs, and she's a project lead of the Best Practice Champions program, and she'll be online to help anyone who has any technical questions in relation to today's webinar. So, our monthly webinars is a means of supporting RNAO's Best Practice Champions and their work in guideline implementation, and all of our speakers that we've had on a monthly basis are those who are actively involved in BPG implementation. And today we have the pleasure of focusing on the work that a long-term care home has been doing on end-of-life BPG and its implementation, and how champions are leading practice change in that long-term care home. So before we get started, just want to keep some housekeeping items in mind. First, we want our webinars to be interactive and engaging, so presenters may ask you questions during the presentation. So if you can please write in the chat box and write to all participants, that would be fantastic. And you have the opportunity, as questions come up, to write them down as they pop into your head, and then we'll also definitely have a time to field them during the question and answer period. So the presentation is going to be about 15 minutes today, and then we have maybe about 10-15 minutes for discussion, and hopefully we'll have a fruitful discussion at that time. And again, just encourage you to type it in the chat box and to say all participants. Just also wanted to let you know that we are also recording these presentations so that people have access to them if they're not able to attend the live session, and that will be available on the RNAO website. So it is my pleasure to introduce to you today our presenter, Rose Lapointe, and she has worked in long-term care for 15 years and has been at Gateway Haven for 5 years. And she has been in the position of clinical care RN for 2.5 years. And she has the fundamentals of palliative care as well as the CAPC training. So she also is a BPSO champion. So for those of you who are not familiar with BPSO, I've mentioned that a few times, it stands for Best Practice Spotlight Organization. So BPSOs are healthcare and academic organizations that are selected by RNAO through a request for proposals process to implement and evaluate the RNAO's best practice guidelines. And it's through that dynamic partnership that we focus on making a positive impact ultimately on patient care using evidence-based practice. And RNAO does provide a number of supports to these organizations over the 3-year period so that they can implement as well as evaluate a number of these BPGs. So because Rose is a long-term care BPSO champion, she receives support from RNAO's long-term care coordinators. And there's one long-term care coordinator for each LHIN on Ontario. So on the line today, I'd also like to introduce you to Suzanne Sweeney, who is an RN, and who is the long-term care coordinator for the LHIN where Gateway Haven resides. So that is it in terms of brief introductions, and now I'd like to pass the floor to Rose.
Good afternoon. So I'm Rose Lapointe. I'm honored to be speaking to you today on end-of-life care during the last days and hours and how the BPSO champions are leading practice change. Thank you, everyone, for joining me today. So this is near and dear to my heart as our team and frontline staff have worked hard to make this a positive and successful experience, not just for staff, but also for the residents we care for and their families. So Gateway Haven's motto is residents first, every day, every way, through best practices. Gateway Haven is located in Wyerton, Ontario, and we are on the Bruce Peninsula overlooking a picturesque bay. We are a 100-bed resident long-term care home, and we're one of 2 of Bruce County homes. We became a BPSO designate in 2017, and we will finish that designation in 2020. We're currently in our 2nd wonderful year. So this is just a few photos of our launch for our end-of-life best practice. So we implemented our end-of-life best practice on May 7th of 2017. At our lunch, we had Heather Penny, who was our administrator at the time. She was our master of ceremonies, and she said a few words. We had Sue Sweeney from RNAO. She's our best practice coach, and she talked about best practice. And we had Dr. John Van Dorp, who is our medical director, and he spoke on palliative care and his experiences. We also had Elaine Bell and Nancy Forgraves from the Bruce Peninsula Hospice come and say a few words. So it was held in our auditorium, and Dietary provided refreshments and made Dove cookies. And I will discuss the significance of the doves further in the presentation. So this is a picture of just part of our team. This was taken at our 1-year celebration that was just this past May. We posted invitations to staff throughout the building. Our celebration was to celebrate staff and the hard work that they put in towards this program. But the celebration grew from staff to family and to residents. There were just some people, these are just some people who are responsible for making the change happen. We had our 4 champions, our medical director, and our administrator. Some other people in our team are the management team, the RIDE coordinator, frontline nursing department, our medical physician, our pharmacy consultant, our rec and leisure department, dietary, environmental team, Bruce Peninsula Hospice, clergy, and the RNAO. Our launch and 1-year celebration and all of our guest speakers were very well received and supported. So training and recruitment strategies provided to our steering committee. So on our BPSO board, we place education opportunities through RNAO, such as the Champions Workshops. We had staff approach us expressing the wish to know more about palliative care and end of life and to become a champion. These people were wanting to be active participants in the change. Some staff were designated to become champions, and they were scheduled to go to the all-day Champions Workshop that was held at Grey Bruce Public Health. And then we also hosted and posted for anyone who wanted to attend Evolving Perspectives on Death and Dying, Implications for Nursing Practice, and that was at the Grey Bruce Public Health on May 17th of this year. And our main guest speaker was Robert Butcher, ethicist, end-of-life care and ethics, and that was attended by registered staff in the Grey and Bruce County Continuum. And this discussion highlighted MAIDS and its implications for nursing and residents. We also had 3 guest speaker panelists who spoke on their experiences in MAIDS and the dying process to give a different perspective from hospital settings to long-term care and community. Communication is key, and one way we communicated is with our BPSO board. On our BPSO board, we list what a best practice guideline is, who our champions are, what best practice guideline we are currently working on, education opportunities offered with RNAO, and this board is kept up to date and current. Supports provided to the steering committee. We have our palliative care committee, and we meet monthly and discuss any active palliative care residents throughout the home. We discuss any concerns or suggestions brought forward by staff, residents, and family. And we discuss the feedback from our post-death survey phone calls. Our champion, frontline staff, and hospice are active members in these meetings, and they offer a great deal of value and input. We have 2 different boards. One was our BPSO board from the previous slide, and then we have our palliative care board, which is also located in the staff hallway. And on this, we list our CAPC graduates, our fundamentals of palliative care grads, who is active palliative and we indicate with our dove and post the dove and the name of the resident, so all staff from all departments are aware who is actively on their journey. Communication, we have our 2 boards. We do spot huddles, impromptu meetings, scheduled committee meetings, and also our Bruce County newsletter. Some strategies used by champion leaders to successfully engage frontline staff in best practice guidelines. So we have brainstorming meetings, and this is our committee, our champions, hospice, and we even access Rec and Leisure because they are normally the person who takes the intake interview and gathers all the information about that resident. And this is shared at our meetings so we can plan for care that covers all aspects of their life. Our unit huddles, this is where we ask what works, what doesn't, what can we improve on. We ask for suggestions and feedback, and this is from our frontline workers. Our monthly meetings, we discuss information that was gathered during these meetings and suggestions and feedback, and then we developed our goals. So then we gradually transitioned and we approached change to frontline staff in stages. This was successful because of all the interest we had from staff and all the positive suggestions and feedback. However, we did have both positive and negative feedback. Some other things we implemented was we designed a booklet. We also purchased 2 palliative care cards, and this was due to family donation. We designed a phone survey for post-death feedback. We designed a checklist that explains which departments are responsible for what. And then our palliative care team suggested an order set. So with the work of our pharmacist consultant and our in-house physician, a palliative medication order set was created. Staff will have this on hand when a physician is wishing to place end-of-life symptom relief orders. And this can also be faxed to an on-call ER physician. They'll complete it, they'll sign it and send it back. This eliminates any concerns that staff might have with not being able to read a physician's writing, and this way here we ensure that the orders are clear. It also allows that on-call physician to know what we can provide here through our emergency stock supply, as our pharmacy is 3 hours away, and on-call pharmacy does not really like to fulfill the narcotic orders without having a physician in and writing those orders directly. We also have a dignity quilt, and this was created by Mother's Fabric here in Wyerton. It was bought and paid for through Residents Council, and it was designed by Residents Council and Charlie Young, who was our previous administrator. Each resident uses this. It's placed over the funeral home stretcher in the body and accompanies them on their final journey through the front door of our home and to the waiting hearse. This is then removed and staff return the quilt back to its place. Some strategies the steering committee are using to sustain the work and the implementation of the end-of-life best practice. So we review and we continue to evaluate feedback given from families. An example of this is we created a checklist that's on top of our cart at a family request. This was because after a family member had passed away, it was 24 hours later and they had received a call from staff asking that hard question of when they would be in to clean out the room. They were grieving and took offense to the call, but once they had time to think about it, and when I spoke to them at the post-death feedback, they thought that maybe this should be placed as a reminder for families so that they won't get that call. So we took this to our committee. We created a list of just reminders that family can have a visual reminder of what the process is after the loved one has passed on. And other families have actually commented that they appreciate having that there since we've put it into place. And this was all due to one of our feedback surveys. We also celebrate staff and the great work they do. We had our first year celebration this past May, and we also have a week of memories for staff, and we had that the week of December 7th, 2017, and we will do this annually as it allows staff to express and celebrate those we've lost throughout the year. We have offered unit bereavement and grief sessions with Nancy Forgraves from Bruce Peninsula Hospice, and this was done on site, and we plan to continue this and offer it as staff found it helpful. They were able to open up and discuss their feelings and thoughts in a small group, and she discussed what grief looks like and gave them handouts to take home, and she just reminded them that even though we spend all of our energy taking care of the people that are here, we also need to look after ourselves. We acknowledge that loss is difficult, even for staff, and we promote the huddles. And we offer unit huddle debriefing for those who wish to participate. So this slide here is just a picture of our booklet that we created. So the front of the booklet is the hands with the dove and the sun, and then our back of our booklet is the dove. So our booklet lists out our definition, our goal, and also the dying person's Bill of Rights, what a family can expect and what they can do. We briefly discuss the signs of approaching death may be in regards to the social and emotional, spiritual and mental awareness, and the food and fluid intake, the sleeping and the breathing, and the elimination in the skin. Our booklet also gives some guidance for families to know when death has occurred, what they visually can expect to see, what happens post-death before the funeral home, and then we've also given some helpful contact information for those who are wanting to apply for compassionate care benefits, and also for information on organ and tissue donation. Families and staff have given great positive feedback on this booklet, and they say that it's been very helpful for them to understand the dying process and still be able to feel like they're an active participating member of the team. The artwork on our booklet, the dove with the hands in the sun, this was created by a staff member here at Gateway Haven. And our doves, so we use our doves to signify, to express someone as palliative. So when a resident goes palliative, we'll place a dove on their room door, and this signifies that they're entering their final journey. So this way visitors and other residents and staff can come by if they wish to visit. And we also place a dove on their dining room table at their seated spot, and this is to continue to hold their place. So again, the staff and visitors and residents know and that they're aware that they're still with us. And we post the dove on the back hallway, and this is to signify that the resident is actively dying and in the final stages, and we put it with the resident's name. These pictures here, so that is one of our palliative care carts, and just a couple of things that we have on there. And then that is a picture of our Dignity quilt folded in half. It is quite large. I like to mention that we also do the post-death survey, and just a couple of the questions that we include on the post-death survey would be, at the end stages of your loved one's life, were you or your resident provided with calm and peaceful surroundings? Were staff respectful of your needs and those of your loved ones? And do you feel supported during that time? In your opinion, was there good communication between you and the staff and the doctor? And then is there anything you'd just like to add, just so that we have some form of, you know, what we can improve on or what they really liked about it? We also had our Week of Memories, like I said, that was in December, which blue ribbons were worn, so they were given out, and this was very well received last year when it was initiated. It was not just for staff, but families and residents were also wearing the blue ribbons, and we had the chapel set up with our palliative board and tea lights and just little sayings posted on the board, and then a digital picture frame that had photos of our past residents and this just gave everyone a nice, quiet, and private place to go to pay their respects. On our palliative care cart, we have music, low-light lamps, some care products, the tea and coffee caddy, a hot water craft, and also some light snacks for families such as crackers and peanut butter and cookies. And these carts are placed in that resident's room for their final days and hours. Our Dignity quilt accompanies them on their final journey from their room and out the front door to the caretaker's vehicle. We also have 2 cots for family members so that they can remain with their family during this time. And we've also had picture frames made for each unit, and there are 3 tiers. So in the first tier, we have Psalm 23. Then in the next one, we'll place the resident's photo. And then in the last space, we place the dove with the hands. We also lower our flag to half-mast in front of our building in honor and respect after a resident has died. And I also want to mention we were also able to fund 10 staff members to attend the Fundamentals of Palliative Care course, and this was due to a gracious donation from a family that wanted to assist and expand on education for our staff. And we did host this course here at Gateway Haven for those staff members. So this here is just our celebration cake and our invitation. So this was our 1-year celebration for all our staff and committee members. We celebrated our successes and our struggles, and we did meet with some struggles. We had staff workload, staff shortages, then staff's own personal conflict of wanting to do more but not enough time to complete it all, and then staff's own personal struggles with death and dying and understanding that we all grieve. We wanted all the staff to feel that we are all working towards the same goal. Our goal is the staff of Gateway Haven provides support, dignity, and respect to our residents, not just during the last days of living, but every day. But during this process, we remind our staff every person's journey is different, but the goal should always remain the same. I believe it takes many threads woven to create a tight foundation, and that is what our champions and our team are. And I feel that those are our threads. I just want to say a special thank you to Sue Sweeney from RNAO, who is our BPSO coach, and I greatly appreciate all the help, guidance, and support you have given during our BPSO journey. And I just want to thank everyone today for joining us on our journey.
Excellent. Thank you very much, Rose, for sharing Gateway Haven's, experiences and dedication to implementing the end-of-life care BPG and to be able to enhance the care and the last days of the life of residents. Thank you so much. I just wanted to, highlight that I think you made a lot of excellent points. The ones that stand out for me is the interprofessional nature and the approach of of the end-of-life care guideline, not only from the staff perspective, but also engaging, the resident council and thoughtfully seeking feedback from family. So I really appreciate that, and the thoughtful engagement of frontline staff at various points where there is opportunity for communication and for dialogue. Also, in the way that you presented this information and the language that you use, I think very much conveys compassion and a culture, perhaps a representative of the culture of the organization when it comes to the approach to end-of-life care. So thank you so much. And I do really like the creative strategies, the thoughtful strategies, and the tailored strategies that you have been implementing to be able to provide a more comfortable journey during the last days of life. So there are some questions I see here. So I'm going to now go into the question and answer period. Please continue to type them in as they come to your mind. But Rose, one question here is, what supports are in place for other residents during the palliative and post-death periods of a co-resident?
So what we do is a a lot of times staff will engage the residents who are on that unit and just, you know, because they do see that the dove is on the door. They do see that the dove is at the table setting. So residents do ask staff, you know, are they still here? Do you mind if I go in and visit?
Mm-hmm.
And staff really encourage that. They encourage them to go in if they're feeling like they want to say, you know, their final goodbyes or just have a few words.
Yeah.
And a lot of times they actually engage with family members who are coming and going. But we do support, if they want to go in, by all means, we, you know, help them get there and help them say what they want to say. And we do acknowledge that they will grieve, because some do, just because they've built that close friendship with some of them. And we allow them to, you know, vent their feelings, vent how they're feeling. We support them. We allow them to grieve. And we've actually even had hospice come in, and they will even come and visit with those people just to provide extra support.
Okay. Okay, excellent. That was going to be my follow-up question, because you were talking about, you know, having, you know, nurses and healthcare workers needing to take care of themselves as well, because the grieving process, and, you know, it's hard for staff, but glad to know that there's also supports available for residents who are also grieving as well. Okay, great. There is, let me see here. Another question is, how does the care provided for the client and family differ between a death from terminal illness in a long-term setting compared to a sudden death in the ER? And that's from Andrew.
So are you wanting to know what we do here compared to what they do in a hospital and an ER department?
How does the care provided for the client and family differ between a death from a terminal illness in a long-term care setting compared to a sudden death in ER? Yeah, I suppose if you're able to answer this, a bit of the, I guess, comparison in approach, I suppose.
Because here, whether they're dying of a terminal illness and we have a long time to prepare, or whether it's only like days or hours or even a couple of hours that we know, okay, this person has become palliative, we treat them the same way. We still put all of our interventions in place the exact same way, whether they're terminal or whether they're short.
And in cases where, say, a resident needs to go to the ER and a death does happen in the ER, what kind of supports are in place? Is there any kind of bridging or anything that a long-term care home can do when a resident passes away in the hospital?
So when a resident leaves here and they go to hospital and they've passed away in hospital, we do still put the pictures out. We still let the unit and residents know that that person has passed on.
Okay.
But as of family support, they still come in. We still have families who their loved one has passed away years previously, and they still come in and they still visit with us.
Okay. Okay. And so open doors, so like, you know, it's part of their grieving process, and that's very much welcome in the home. Okay, excellent. Andrew, I hope that answers your question. And then Andrew also had another question. What sort of things are housed in the palliative carts?
So in our palliative carts, inside for our care products, we'll put like mouth swabs, face cloths, some products that they use, whether it's a brief or a pad. We also put gauze in there to keep their eyes clean, just stuff that the PSWs would need on hand just to, you know, keep them freshened up. We also have gowns in there for them. And then we have, like I said, our caddies for our snacks and our coffee and that sort of thing on top. And then we have a music selection in a binder that's kept in my office, and staff just go and whatever type of music the family are wanting, that CD player and the low light stay in there with them.
Okay. Okay.
And also on top of our cart, we also include our booklet of information that I was talking about, and then our checklist is also there.
Okay. Okay. And I'm assuming, like, the all staff, are aware of everything that's on the cart and their uses, and there's been some sort of education and dissemination about.
Yes.
Yeah. Okay. Excellent. Thank you, Rose. There is another question from Nasria. What services are available for a person at the end of life who doesn't have a family member and who is paying for the funeral service?
So people who don't have family will usually still have some sort of a power of attorney scheduled to them, whether it's public trustee or a friend or relative of some sort. And it's usually from them that we get that information of, when the person's passed on, which funeral home they want, that sort of thing. And then we just contact the funeral home, and then the funeral home contacts those family members or the public trustee for how it's going to be taken care of for funds. Okay.
All righty. Thank you. And I believe on the, is it long-term care, the Arneo?
Can I just add one thing?
Yes, of course.
Also, for those who don't have any family that come in to visit and they are at the end of life, we do have the hospice volunteers that'll come in and sit with them, and we have that relationship with them.
Okay.
And they will come in and provide the one-on-one compassionate care visits.
Okay.
And a lot of staff go in, a lot of staff go visit. Really, that person doesn't lay there alone. Like, we do have the supports of staff and the hospice volunteers.
Okay. Excellent. Thank you so much. Samantha has a question. What tools do you utilize to identify that someone is nearing end of life?
So that we look at, their intake, whether it's food, fluid. We look at, they're not responding, they're always sleeping, that sort of thing. We have the doctor come in. The doctor assesses them, and a lot of times we've had people who we've deemed as palliative, and, in 6 months and 9 months, they're still here and they've gotten their second breath. So we do a full assessment of them, and then we let the doctor decide and deem them as palliative, and then that's when we put all of our interventions into place for them.
Okay. Is there specific tools that Gateway Haven uses for this assessment?
No, it's just our nursing assessments that we go by.
Yeah. So just a comprehensive head-to-toe type of thing?
Yeah.
Okay, perfect. Deb would like to know where you purchase your carts.
Oh, that I could not tell you. I do not know the answer to that. But we were able to fund them just because the family was able to give us such a gracious donation that we used them to purchase our 2 palliative care carts.
Okay. Okay. It's a great idea, so thank you. And I believe you had mentioned this before, perhaps an iteration for Aaron. How long after passing does the phone survey occur?
Usually I try and do that around the 2 to 3 week mark. Sometimes, though, if family are coming in, I do like to ask them when I see them in here just collecting belongings and stuff like that, if they mind if I give them a call. Some families have said, please don't call me, and I respect that.
Yeah.
But the ones who have said, yeah, sure, no problem, call me in 2-3 weeks, I do that. However, there are some families that just would rather just talk to me right then and there. So it does vary in time, and it's not always a phone call. Sometimes it's a sit down and have a conversation. Yeah.
So you definitely take their lead in terms of how they would like to share, if they want to share.
Yeah.
Okay, great. Another question from Samantha. Do you have any barriers to the management at end of life?
None that I can really think of off the top of my head. No, just that all of our staff, this is one best practice that everybody has really embraced.
Mm-hmm.
So there's not many barriers that we've met other than, you know, they're trying to do their best with sometimes very little time,
mm-hmm.
and then just personal struggles. But other than that, everybody's been very supportive.
Okay. And this was a guideline that was identified by the staff as a need?
Yes.
Okay. Okay, so there was already that engagement and buy-in, hey, we need this.
Yeah, we didn't have to really push this one. This one was pretty easy for them.
Okay. Okay, perfect. And then, as you said, there is, you know, always challenges with the grieving, but you said you provide debriefing and huddles, opportunity for staff to do that, as well as for family. There's opportunity there. So, and then staffing, I think, is sort of like a universal challenge. And so just balancing competing priorities.
Yeah.
Okay. What medications are on your end-of-life order set? That's a question from Shannon.
So we have, on our order sets, we list pain medications, and it'll vary depending on if you have emergency stock available at hand in your home or not. But in our home, we only have hydromorphone and morphine, so those will be offered. We also have on our medication order set the need for Ativan or something for anxiety, something for high agitation, secretions. So it all depends. Everybody's emerge stock is going to vary. But this way here, we only list what we have in-house on those order sets. So like I said, if our doctor is not available and we have to contact an ER doctor, they're not really wanting to come here and assess anything. They just want to see, okay, I'll give you end-of-life orders. So here we send what we have, and then they fill in how often they want it, the dosage that they want it in, and then they can just fax it back to us. Okay.
Okay. Excellent. So it's customizable. Okay.
Yeah.
I'm going to try my best to get through all these questions and then leave the last 2 minutes for closing. But Claudia says here, in acute care, I find families are anxious regarding oxygen and providing more oxygen for comfort. In the last days and hours of life, if there are any benefits of using different types of oxygen, i.e. nasal prongs versus Venturi mask, does it make a difference in terms of patients' comfort?
So what we do is we do offer oxygen nasal prongs, and we do explain to family, you know, what the benefits are. If somebody's a mouth breather and they're not really breathing through their nose, we can tell family, you know, we can put that oxygen if you'd like, just on the inside of their mouth so that they're still getting it. And some families don't like how that looks, so they'll just say no. So we go family by family, and yes, some families are very, very anxious and they're wanting, you know, just to put the oxygen on or don't put it on. I just want them to be comfortable. I want them to look how I've always seen them look. And we just go by their lead. Like, we really do take a lot of our cues from our families.
Right.
Just because it is their time with their loved one and it is their memories, so we want to make it as easy and comfortable for them as possible. So we just, if they want it, we are more than happy to put it on, and some families want to know, is it benefiting them? We check their oxygenation, and if it's really not making a difference, we tell them it's really not making a difference, but if this is something you want, we will continue to provide it for you.
Okay. Okay, thank you. Excellent. Samantha wants to know, do you use the PPS score or the CHEST score from the RIE-MDS?
We do use our PPS, and all of our nurses know how to score on the PPS. And usually when we get to a 10 and 20, staff are more, I want to say, heightened on that they're starting to enter their last stage.
Mm-hmm. Okay.
But yeah, we just use the PPS score.
Okay. Okay, thank you. And let me see here. There's a couple. Andrew. So, Rose, you had mentioned that some of the staff at your facility attended the Fundamentals of Palliative Care course. Where is this course offered?
So we contact Liz Laird, who is through, I believe, St. Joe's in London, and she sets up, they post on a website for the palliative and the CAPC courses, and they give you dates of when these courses are going to be available. And what we did was, because usually they like to run a class of at least 10 people, and we had 10 staff, so I just contacted her and asked her if she would be able to set up and do a course here, and she was more than gracious and accommodated us.
Okay.
So Liz is the pain and symptom consultant for this area, and they're found throughout the province, and you can access them, and they are the ones who will organize the courses.
Okay. Thank you, Sue. Thank you. Okay, excellent. So there's just one last comment from Shannon, and I'm sure you'll agree with this, but just to point out that the use of intentional language and remind people that people aren't deemed palliative, rather the approach is a palliative, the approach to care is palliative.
Yeah.
So yes, definitely we're talking about a palliative approach to care here.
Yes.
So I think that's about it. Thank you, Rose, again, for an excellent presentation and for engaging discussion with all of you. And thank you, Sue, for the support that you provide Gateway Haven and Rose. I think it was an excellent webinar. So just to round off today's presentation, just to let you know, Rose's presentation as well as the recording will be posted on our RNAO's website. And we do continue to do these webinars on a monthly basis. So if you please fill out the evaluation survey to see how we did today, and also for future topics, that would be fantastic. And if you have any questions regarding this or the Champions program, please contact Andrea Stubbs at astubbs@rnao.ca, and she's the program lead. So thank you very much, everyone, for joining, and thank you, Rose and Sue, for your efforts and for the excellent work that you're doing at Gateway Haven. And I hope that everyone has an excellent afternoon. So thank you.
Thanks.
Thank you very much.